See you guys. Okay, great. And so we're gonna go ahead and get started. Let's see, how many people here? 17. All right. Great. Great. Yeah, so let's go ahead and get started. We'll start off our ECHO intro slides. Next slide. As always, ECHO is free CME, distance technology online learning. We have a community here and we're open for case discussion and interdisciplinary expertise. So all of you are also experts and have seen similar things and can also share. We really welcome your interactivity. Next slide. And so please share any cases. Of course, do so with HIPAA compliance. Any geriatric topic is fine. And we love challenging cases. Next slide. So we just have to make sure everything is HIPAA compliant and that we create a safe learning environment, that we're all encouraging each other. And just a reminder that these any ECHO consultations do not create or establish provider-patient relationships between any ECHO specialists and patients who are being presented as cases. These are purely for education. Next slide. In order to receive CME credits, make sure that after you've registered, we complete the evaluation, which will be put into the chat box. The link will be put in the chat box. And as you know, there's a chat tool at the bottom. So enter your name and the others joining with you on the camera today and hit enter. And then there's a mute button. Please mute yourself if you are not speaking and unmute, please, if you want to share. Next slide. And just introduction. So we have our hub team here as usual. There's me, the course director for this ECHO Geriatrics Clinic. There's Sarah Tompkins. She is our social worker, licensed clinical social worker. And Mary Gotham is here for retired public health nursing. And I'm not sure, I don't see the others, but anyway, so if they join us, that'll be great. Next slide. And then finally, we want to introduce, we are really happy and pleased that we have Dr. Daniel Fischberg with us joining today. He is the medical director of the Pain and Palliative Care Department at Queens Medical Center in Honolulu. He serves as professor and chief of the Division of Palliative Medicine with the Department of Geriatric Medicine. He holds board certification in internal medicine, pain medicine, addiction medicine, and hospice and palliative medicine. And he's a fellow of the American Academy of Hospice and Palliative Medicine, where he completed service as chair of the Education and Learning Strategic Coordinating Committee. So he's recognized as a national expert in areas of enhancing pain and palliative care education to healthcare professionals, improving access for palliative care for patients at all stages of life, and advancing evidence-based practice in palliative medicine. And we are pleased to have him. He will be speaking to us about prognosis. Thank you, Dan.
Thank you, Aida, for having me here. Let me just share my slides. You can give me a thumbs up. Are you able to see my slides, Aida? All right, thank you. You know, this was a fun invitation that my colleague Dr. Wen gave me. It's a pretty broad topic, and it's something that I really have to do as a palliativist every single day. And so it was kind of fun to actually step back and kind of look with a very broad perspective of this broad topic. So I found it interesting to sort of think about prognostication as a broad topic, and my hope and prayer is that I manage to make it interesting to you for the next 30 minutes or so before I toss to our illustrious panel. So when I started thinking about this, when we think about the traditional goals of medicine and the healing arts, obviously comforting the sick and their families is always, for millennia, been very important. Promoting and restoring health and well-being, actually, other than like some surgeries for gangrenous limbs and appendices and whacking off some tumors and things like that, are medical interventions that could promote and restore health. Really, it's probably less than 100 years that we really have things that really meaningfully change the natural history of course, with all the modern medical miracles that we have. And really, the comforting the sick and their family was a priority for millennia, but also predicting who's going to survive. So the art of prognostication really has been an important part of the healing arts for millennia. Again, even before maybe we had so many of our modern tools that could really help us with this middle focus here on promoting and restoring health and well-being. A lot of what we were doing was comforting the sick and the family and predicting who will survive. So prognostication is something that has a long history in the healing arts. And we often sort of, talk about this crystal ball that all of us wish we would have. And I think we all know that it's a pretty hazy ball a lot of the time. And so I'll be talking about, how we move forward with trying to predict things and deal with the fact that it's not a perfect crystal ball for us. And part of that is acknowledging, with humility, the limits of our knowledge and predict with confidence when we can be confident. But in the vast majority of times, there's always going to be sort of a range of what we can be talking about. And so how to communicate that level of uncertainty. So my objectives today, I want to talk about some of the aspects of the prognostication. I want to talk about some general guidance about how to discuss prognosis. And then I'm going to share with you a list of tools that you probably are familiar with many of them, if not all of them, and some special considerations for a variety of situations, again, before tossing it back to our panel. I have no financial conflicts to disclose, but I do need to warn you that there certainly may be some dad jokes along the way. So if you're triggered by that kind of humor, consider this your warning. So when I started thinking about prognostication, some of these considerations really come to mind. And I'll delve into each of these a little bit more. Who's asking? What exactly are they asking? In terms of it comes to prognostication, sometimes we're asking about survival. Will I make it through this? How long will I live? But sometimes there's also a question of functional recovery. My loved one is in a coma. Are they going to recover from that? Will they go back to being the person that I know and love, to living their life as they did before? Or, for example, somebody perhaps with an early neurodegenerative disease, ALS, or dementia, what's my future going to be like? Or how can you prognosticate that for me? Helps to understand why the question is coming. Why is somebody asking about prognosis? It's not always so obvious. This question that I alluded to earlier, how certain can we be in what our prediction is going to be? How do we discuss both our certainty and our uncertainty, and when to bring up prognosis? So getting into the who's asking, okay, so certainly the patient might be asking, but you want to be certain you understand what exactly it is that they're asking, because you don't want to answer a question that they're not asking. And it often starts to help by learning, what do they already know? So what have the doctors explained already about what's going on? But again, getting as much clarity about what exactly they're asking is helpful. Don't assume. Don't assume if they want to know if they're going to be cured or not cured or live 12 months or whatever. Same thing with the family member. You want to be sure what exactly they're asking. Take some time to learn that. Again, just like with the patient, what do they already know? But of course, don't assume that they're authorized to be receiving this information. So make sure that when you are sharing information, make sure that you're talking to somebody who has been authorized to receive, protected health information of the individual. Somebody else that might be asking, well, the healthcare providers might be asking. I did a consult just yesterday where the nurse was saying, do you think that hospice would be appropriate for this patient? Turns out the patient's having a complete response to the treatment. So the answer to that question is no, but it was a good question. What about the payer? The payer might want to know, could this person benefit from some additional services, like we're very fortunate to have in Hawaii, some of these additional community supports, or an agency might want to know, is this patient eligible? If their prognosis is serious enough, are they eligible, for example, for hospice? So again, I mentioned it earlier, it's good to know what precisely somebody's asking. Sometimes people are looking more for reassurance than an actual you pointing to the calendar and saying, this is the day you should not expect to live beyond. Sometimes somebody wants really reassurance that they're not dying today, they're not dying this week, that there's hope that they can have an improvement in their condition, their symptoms can be controlled, their function can be improved, and their life can be extended. So if somebody's looking more for reassurance that there are things to hope for, it's good to know about that rather than start talking to them about months and days and so on. Sometimes people are looking for a little more specific information about the plan. How long can I expect that I will be independent? When do I think I might need extra help? When might I lose the ability to make my own decisions? Or if I have this bucket list trip I really want to take with my family, should I think about moving that ahead? All kinds of financial planning things and things like that. So there definitely are times when people really do need your best prediction regarding time, but that's not always the question that's being asked. So that's why I said before, really try to do your best to understand what exactly they're looking for before you just start talking about time, because that might be what's on your mind, but it might not be what's on the patient or the family member's mind. When it comes to communication preferences, one of the things that's always stuck with me, Robert Buckman was a British oncologist. Many of you are familiar with his SPIKES protocol about breaking bad news. Part of Dr. Buckman's protocol is understanding the P is the perception, the I is the invitation. So what does the person know and what do they want to know, right? That's the P and the I. And Dr. Buckman would say, learning about the individual and how they want information. Are you the sort of person who, and maybe that's a little too much of a Britishism for me, so I had to sort of change it a little bit, but I definitely was very inspired by that. And I always do ask people, besides what they like to be called, how they like information to flow from the doctors. Do they like the doctors to sit down and explain everything in plain language, good news and bad news? Are they the sort of person that finds that information helpful to understand, to plan, to cope? Most people say yes. Or are they someone who finds too much information a little overwhelming, and they actually feel if the doctors have something of a serious nature to discuss, they prefer to be joined by or replaced by, a trusted family member or friend. So it definitely helps me to learn what somebody's communication preferences are before you start, sharing information about prognosis. Another reason why people might, be asking is this, as I said, to screen for unmet needs. The surprise question, which many of us are familiar with: would you be surprised if this person died in the next year? That was actually developed not actually as a prognostic tool, but as a screen for potential unmet palliative care needs. We've adopted that, and are very grateful that our colleagues in the emergency department have picked up on it. We've asked them if they consider using that as a screen for potential unmet palliative care needs, the surprise question. And that's led to a robust uptick in our palliative care consults from the ER. But that's one potential reason that people might want to know about prognosis. And then, as I mentioned before, confirmation for eligibility, right? If somebody's going to be getting hospice services, we need to confirm a prognosis of to the best medical judgment of 6 months or less. Talked a little bit about this before, about how to discuss. Of course, knowing somebody's preferences is really important when thinking about how to discuss prognosis. But some general rules: yes, understand what the person who's asking, what their motivation is. When it comes to survival, I think the concept of introducing the concept of the median, not the mean, but the median, is really helpful. That's typically the way we think about survival in oncology field. So language that my oncology colleagues might say, typically patients might expect a survival in, a short number of months or years. But adding, because it's a median, right? Some will do better, some will do less well, right? That's what the median means. Half the people are going to make it or will pass before this time point, and half will exceed it. And so really what I was taught, and I think most people find really helpful here is talking in a range, right? Don't say you've got 6 months, we talk about, maybe weeks to months, or when we're talking about really short survival, actively dying, we might talk about hours to days. Gives people more of a sense. And again, that concept of some will do better and some will do less well, to understand that it's a statistical kind of situation that we really can't look at a date on the calendar. I think there is a general perception out there that the medical field has a much greater precision in these prognostic estimates than we really do have. That was talking about survival. When we're talking about recovery, somebody who's had a stroke, somebody who has had a traumatic brain injury, I think it's probably helpful to talk about what's the best case scenario and what's the worst case scenario. So, oftentimes, thinking about serious traumatic brain injury, the bad outcomes are death or severe disability, or something like that. And the good outcomes are just minimal levels or no disability. I would counsel people to avoid the traps that I see of really inappropriately expressing overconfidence. So when somebody says they're never going to wake up, and then 3 days later, the patients open their eyes and looking at the family and so on, it's very hard to rebuild trust in the medical system when somebody has made such a strongly, prematurely confident prediction of a bad outcome. Maybe there's going to be a poor outcome still, but to say they'll never open their eyes again, that's just not usually appropriate early on. To say, you might be able to say there's not going to be a good recovery or unlikely to be. But so just be mindful about how confidently you state things early on, because it can make things a little harder later on. You certainly shouldn't be withholding if there's very clear, strong evidence that survival is not possible, recovery is just not within the realm of medical feasibility. By all means, it's appropriate to be candid about that. But again, so often it's a little gray, and exercise caution in being overly confident. I think emphasizing that time will tell. This is how the situation looks to us now. The next few days will be really important. These are the things we'll be watching for. I think that's a really good time to align yourselves with the family. You use words like, this is what we're hoping to see, because you're legitimately hoping to see this recovery, this good outcome, and this is what we're worried about. And you're worried, and that's obviously, the family has hope and the family has worries, so that does allow you to align yourself with them. And so that time, it's going to give you more information, but also you can use that time to try to provide emotional support and develop a good relationship with the family that you're trustworthy. Okay. So I'm thinking of reasons to go to Switzerland. The flag is a big plus. Okay, Dr. Wayne, you're going to be my barometer when I see groaning or, oh no. Okay, this is like one of the first studies on prognostication that really caught my eye. It kind of dates me because I was a fellow when this came out. And it was Nick Christakis and a colleague did a prospective cohort study looking at 5 outpatient hospices in Chicago. 343 physicians provided survival estimates for almost 500 patients at the time of referral. And the question was, how good did the docs do in predicting the future? What they found was that only about 20% of predictions were accurate, meaning within 1/3 of the actual survival. About 2/3 were overly optimistic. The patient did not do as well as the doctor predicted. And then a small percentage, actually, the doctor was overly pessimistic and the patients did a little bit better or significantly better than the doctor might have predicted. There were a couple of modifiers. More experienced docs were more accurate, or tended to be more accurate. Interestingly, though, the length of the relationship between the doctor and the patient, that decreased accuracy. So perhaps there was a lack of objectivity there. But this is the number, I put it in bold. This is really what stuck with me from this study. You took what the doctor said and you divided it by 5.3, and that gave you the best overall estimate of survival, which has kind of intrigued me, right? Because this was a hospice population. So if you say, oh, the doctor was referring because they thought they had a less than 6-month prognosis, you divide that by 5.3, and boom, you've got our national average length of stay on hospice, which is, a little over a month, something like that. So interesting study. And this was in a hospice population. So this is, a population that has a pretty limited prognosis already. So you can see already, that you can imagine in someone who's not in the last 6 months of life, our ability to predict prognosis, and it can be difficult. So that's to say, these predictions, they're not always on target, right, if you will. And we do our best because this is a fundamental requirement for being a healer, is to try to help predict the future. But again, we're imperfect at it. Now, a lot of people look to artificial intelligence as something that's going to come and fix this problem. And I think that's probably true. It is going to make it better. There are algorithms and artificial intelligence programs out there that currently do a better job. And that was just a study I saw like a month or two ago, comparing oncology predictions to an artificial intelligence, and the computer did a little better. I would say that this maybe isn't quite ready for prime time, or it's not quite readily available. We've got in our health record, there is a something that's supposed to help us predict 1 year survival, being low, medium, or high risk. I have to say, it doesn't seem to be performing particularly well. I mean, I'll have patients who are not going to survive the admission. Clearly, they're actively dying, and they get a low risk of a 1 year mortality. So the machines will be better than us in time. The system we have available to us right now, I'm not so impressed with it, but I think it will be there. But that's something to look forward to, or if not look forward to, look to the future for. For now, we have these prognostication tools, which we can all use on our own. Many, if not all of them, you're already familiar with. I'm just going to review some of them here. And these are the ones looking at survival. So some common ones are the Palliative Performance Scale or the Palliative Prognostic Score. In oncology, we've got the tried and true ECOG performance status. For heart failure, there's the Seattle Heart Failure Calculator. That's something online. I'll show you a screenshot of that, but you can pull that up. These are all available publicly. For liver disease, the Child-Pugh-Turgot scale, the MELD, again, you can pull that up on an app on your phone. It helps you predict 1 year mortality and liver disease. Modified Charlson comorbidity, often used for end-stage renal. And then my colleagues in geriatrics, very familiar with the FAST for dementia, and the mortality risk index as well. So just to review some of these, the ECOG performance scale, 0 is fully active, able to carry on all activities. Basically, the disease is not having any impact on you at all. The 1 is, there's some mild restrictions, but you're up about, you can do light housework, you can do office work. But 2, you're ambulatory and you can do self-care, but you really can't carry out meaningful work activities. But you are up and about more than 50% of your waking hours. By 3, we've got limited self-care and confined to bed or chair more than 50% of waking hours. And then 4 is completely disabled, can't carry on self-care, totally confined to bed or chair. Compare that to the modified Charlson comorbidity index. You get different points for each of these comorbidities. And you can see, though, if you drop down to the bottom and look at the annual mortality rate, even at the very high, where you've got more than 8 points, it's still only predicting a 0.49 annual mortality rate. So that's, that's a coin flip, right? So you get the sickest people and they're still saying for 1 year, 50-50. So, it's not a super high level of precision, right? Palliative performance scale, little more granular than your ECOG, but it's the same kind of thing. It's looking your activity level, your ambulation, your self-care, intake, level of consciousness, and not unsurprisingly, median survival, dropping as you go from 100% downwards. The FAST, again, geriatrics colleagues familiar with this, the functional assessment scale. Generally, for hospice, which with that 6-month prognosis, we're looking for at least a FAST 7, which is the most advanced. And even for that, you have to have an additional dementia-related comorbidity like aspiration pneumonia or repeated hospitalizations. Here's the Seattle heart failure model, which is kind of fun to play around with. It's very complicated, lots of buttons and things to play with. But it's interesting. It gives you a 1-year, 2-year, 5-year survival and mortality. It gives you a mean life expectancy. And what's fun about this one is you can sort of plug in different interventions and see how they might modify survival. So this is a pretty sophisticated model, and you can see that there's actually a smartphone version over on the left. So this is available to you. You can download it. You just look at Seattle heart failure model. But this degree of sophistication is helpful because, again, heart failure is a great example of a disease where it's really tricky to prognosticate. We generally think, cancer is one of the more consistent things that we can predict reliably based on the ECOG. Performance status does reliably decline as you near death. And yet heart failure is really a very different model where people can have multiple exacerbations, recovery of functions, another exacerbation. You're never exactly sure which exacerbation is pre-terminal. So I'm going to get back to the surprise question. We talked about that a little as the sort of a screening tool for unmet palliative care needs. And again, if you're not familiar with the surprise question, it's would I be surprised if this patient died in the next 12 months? But this is a systematic review that actually looked at this tool. Does it have value, not just as a screening tool, but as a value as a prognostic indicator? And they looked at 16 studies with a little over 600 patients. And they looked at it in terms of predicting death for 6 to 18 months. That was generous because 12 months. The sensitivity was only 67%, specificity was 80%, and the positive predictive value, though, was only 37%. It's a little tricky because we call a positive predictive value is yes, I would be surprised. But basically, if you said yes, I would be surprised, sorry, that's the negative predictive value. That 93 of those people survive. But for the ones you wouldn't be surprised, it was only 37%. So not performing tremendously well. Sorry if I made that overly confusing, but it is confusing because the positive is actually a negative answer to this question. They did, as we've alluded to before, better discrimination in patients with cancer. So it performed a little bit better when the patient had cancer because we're a little bit better as clinicians in terms of predicting survival and being surprised less often by survival in cancer. Okay, Aida, this is my step ladder. I never knew my real ladder. I want to switch now and not talk so much about survival as about recovery, okay? So for example, after somebody has a stroke, if you're being asked to prognosticate, more often you're not being asked, are they going to survive? You're being asked, what's their survival going to look like? How will they be? So on so many of these slides with neuro insults, I'm going to say consult neurology because I just have to say sometimes they'll be consulting palliative care before they consult neurology, and I say, guys, I'll do what I want here, but I'm pretty sure the family would want to hear what a brain specialist has to say about this brain problem first before they talk to the palliative care doctor. So, so always get input from neurology. Even if I'm rather confident in my own predictions, I still want it, you know, give the family the very best, give the patient the very best by having the right specialist come by as well. So input from neurology. It's helpful to know, you know, so most recovery from stroke is going to occur in the first 6 months. In general, a lot of these neuro syndromes, we're better at predicting when things are going to go poorly than we are at predicting when there's going to be a good recovery. So an NIH stroke scale of more than 16, dysphagia beyond 3 to 7 days, coma for more than 3 days, those are all predictors of a poor outcome. Thinking about prognostication after traumatic brain injury. Once again, input from neurology, that's almost always going to happen, at least, because they're usually on a neuro unit. So the Glasgow Coma Scale is very helpful for helping us predict immediate survival, who's going to survive to discharge. But very often, you know, we're much more interested in the long-term outcomes, who's going to survive with a good versus a poor functional neurologic outcome. So the Glasgow Coma Scale and the crash scale, I'm going to show you a little bit about those. So just remembering, I said this before, you know, there are sort of two flavors of bad outcome, or there's bad outcome and good outcome, and bad includes death, this unresponsive wakefulness syndrome, which we formerly referred to as a persistent vegetative state, or severe disability, total care dependent. Good outcome is just only moderate disability, which is somebody who can live independently and work in a supportive environment. Good recovery is minimal or no deficits, and they can work and socialize normally. The crash calculator is online, and you can get in there and play with it. You plug in the country, the years, what the Glasgow Coma Score is, the pupil function, a couple other things, and it will give you the risk of 14-day mortality, and then the risk of that unfavorable outcome at 6 months, which again is going to be moderate, or I'm sorry, anything other than moderate or minimal disability. Okay, and then, you know, the last scenario I really wanted to talk about was anoxic ischemic encephalopathy. Again, neurologic input, very important. And again, we're better, we can have more confidence in saying when things are going to not go well, and there's a little more uncertainty about to reassure people there will be a good outcome. So these are consistently pretty dismal findings. An absent pupillary reflex at 24 hours after CPR, or after 72 hours for those that initially had it, and absent corneal reflexes. So I don't need a neurologist to do those. I don't need an EEG. I don't need an MRI. I can do those things, but I still ask. It's still, the family deserves to hear from a neurologist about these things. Okay, so those are the main things I thought would be helpful to cover. So in summary, I would say it's very important to be mindful about what exactly is being asked. Are we talking about recovery? Are we talking about survival? Who wants reassurance? Who wants some additional services to know if they qualify? Try not to fall into that trap about being inappropriately, prematurely confident. When it's appropriate, be confident, but there's lots of opportunities to be cautious and have some humility. Obviously, I've said it many times, but bring in the right specialists to help you with prognosticating. Use the best communication tools you have, and use those disease-specific prognostication tools. As artificial intelligence becomes more readily available and improves over the human, make use of that. Until then, really your best allies are time and the use of your interdisciplinary team. And you use that time for the team to provide support to the family, informational support, emotional support, build that rapport, and to increase your own prognostic confidence about what's going to happen. So Aida, I want to thank you again for the invitation. those were my thoughts on prognostication. I will hand it over to you and the illustrious panel.
Okay, thank you so much. That was very thoughtful and lots of great tips. It's always good to be reminded, right, to step back and think about why are they asking. That's a great reminder. We have several questions here. Maybe I'll get started with that. So Dan Saltman asks, can you give examples of individual factors that would estimate and inform whether a specific patient might do better or worse than the median?
Okay, so if I heard you right, so what's going to make people do better, worse than the median? Okay, it's hard to generalize, but when I was talking about median, I think I was largely referring to oncology. Well, certainly performance status, I think I said, is the number one. So, you know, if somebody's running marathons, that's probably gonna, I would bet on them to beat the odds. If somebody already has a markedly reduced performance status and is in that situation where more than 50% of time is in bed or chair, I think that's going to decrease it. Comorbidities, you know, the more you add up different issues, somebody's dealing with a major heart problem, a major lung problem, and their cancer, somebody's on dialysis, those comorbidities you would factor in and say, oh, I might consider them in the half that won't do better. If we're talking about something that was sort of sudden onset, you know, generally neurological insults, we do think the brain has a little more plasticity to it the younger someone is. So, you know, kids can have some pretty amazing recoveries from traumatic brain injuries. And you know, we lose some of that plasticity, flexibility as we age. I'd be interested in, those are just my first thoughts, you know, so comorbidities, functional status, age has an impact. Other thoughts from the panel?
Yeah, no, in geriatrics, we definitely think about function a lot more than that. We put a lot of weight on function. I had a question from Dr. Kong. How do you think short expectancy entering hospice care is affected by the acceptance and preparation for imminent death, as well as removal of any treatments against the underlying condition? So it's self-fulfilling prophecy kind of a thing, or is this?
Yeah, you took the words out of my mouth, Ada. I mean, it's hard to know. I'm not sure what you mean, short expectancy, but we don't often don't.
May I clarify?
Please.
Yeah.
Doctor? Thank you for the presentation. The first study that you talked about when you were a fellow, you talked about that 1/5 was 1/5 of the predicted was what ended up, right? Something like that.
Yeah, exactly.
Going into hospice. So doctors predicting how long people were going to live in hospice was grossly overestimated. And it turned out that they didn't last nearly as long. And so that's the basis for my question. How much is just entering hospice and removing treatment and expecting that nothing else is going to be done to cure the underlying condition is going to shorten lifespan?
Yeah. It's interesting because there's another question in there that I think sort of reflects on this. As Aida said, it's hard in some of these studies. There were some other studies outside of the hospice literature that did make it's actually in the neuro injury studies where the question of self-fulfilling prophecy. If somebody comes in and has an injury and the family is told this is catastrophic, there's no recovery, that certainly can be a self-fulfilling prophecy, because the family many families might take that guidance and say, oh, okay, then let's, so in terms of survival, the figures that we have on survival for some of these injuries, we don't know what the natural history of that would be, just because people might make different choices based on what they're told. Your question is somewhat without an answer, and it's in the sense that sure, it's possible. But what I would say is the question that comes up is the only real data, quote unquote, we have on survival in hospice. Actually, in cohort studies, it's not prospective studies, but actually there have been studies that shown a slight survival advantage to being on hospice. Again, not high quality randomized controlled trials, they're just cohort studies like, well, these people went to hospice and these people didn't, and they seemed kind of similar at this point in time. And then the people in hospice had a longer survival advantage, and it's a couple of studies that I'm aware of too that showed that. So that's the only counter I would have to that. But I do think that I think in the neuro injury field, I think there's definitely that potential that self-fulfilling prophecies.
No, Dr. Marita put a link in there for an article that kind of talks about that a little bit. Do you want to comment on that, Naomi?
Can you hear me?
Yes.
Yeah. Well, I was just taking a look at the article. I mean, there's a number of articles regarding that anyways, and that's an early article from the NHCPO, National Hospice and Palliative Care Organization. So that's 2007, but since then, and subsequently in the last few years, there are other articles as well. So that one showed that people in hospice live 29 days longer. So that's 2007. I don't know what the actual number is, but certainly there are some recent studies. I wasn't able to find it at this very moment. And then the other thing I said was in response to when they get to hospice and we just treat symptoms, but actually I aggressively treat patients to comfort. And oftentimes it will affect their disease trajectory as well. And I think a classic case would be CHF, because I'll adjust their blood pressure medicines, their heart rate, diuretics, and maybe their EF will get better, things like that. And just FYI, is that enough?
Yeah, so that was one of the, so thanks, Naomi. I mean, that's definitely one of the studies I was thinking of. That was the first one. It's kind of an industry study, right? It's from an HPCO. It's a cohort study, but it's the data we have. One of the other studies that came to my mind is Nate Goldstein and colleagues did one in heart failure. And again, similar, patients that were on hospice had much better outcomes, including survival. So we're never going to get higher quality data than this, because we're never going to do a randomized controlled trial of assigning people to hospice or not. But anecdotally, I completely agree with what you say, that generally with all the additional attention that people get with hospice, they oftentimes do a heck of a lot better. And we're generally continuing, like for heart failure, heart failure medicines are all palliative, right? So we're not like stopping them. We're continuing them, we're adjusting them, meticulous management of their diuretics. So yeah, it makes total sense that they would do well or better.
Yeah. Anyway.
Yeah, and I think.
Can I
was going to say.
Can I add one other thing? Remember that a significant number, I think about roughly, we're recording it, so I probably shouldn't say it because I have the numbers, I can get them. But it's about a third of people will disenroll from hospice once they're enrolled. A significant portion of those people disenroll because they no longer qualify as being terminally ill. Okay, so again, it's not abandon all hope when you go on hospice. It's not clearly inferior outcomes. Some people are getting quote unquote cured. They're improving so much on hospice they don't qualify anymore. They graduate, right?
Yeah. Now, in fact, yeah, we get plenty of those who graduate hospice and nursing home care because they have this additional supervision and medical attention that they may or may not have had at home. Yeah, in fact. So before we move on to more questions, I also want to highlight a couple of our interdisciplinary team folks. Sarah mentioned, thanks for highlighting the importance of communication preferences before sharing prognosis and collaboration with the team. So Sarah, I didn't know if you wanted to comment on how you can really help with that. How does social work and nursing help with that?
Yes, I think as Dr. Fischberg mentioned, it's, the communication is so critical, because if you don't really understand where the patient or client is coming from to begin with, you really don't know how, you might be moving in the wrong direction, right? And for sure, it's not just social workers, but other team members have invaluable information, because oftentimes our patients say different things to different people on the team. What they tell the nurse's aide is really going to be different than what they tell the social worker or physician, no? So thank you for highlighting that, Dr. Fischberg.
Well, you're most welcome, but it's only through the School of Hard Knocks that I learned it the hard way.
Yeah, they save your butt a lot, right? I know for sure. Yeah. We actually also had, so Naomi mentioned that the ones who graduate tend to have the dementia, CHF, and COPD. Absolutely. Also, there's a question from Dr. Khan about the incidence of DVT and PE in hospice patients. Do they preventatively get anticoag when bedridden? I guess it's more of a hospice question.
Yeah, I'm going to toss to any of my hospice colleagues. So that's an ongoing question that we actually have, and there's not a right or wrong answer, because the hospice patients are often at really increased chance of bleeding and things like that. But with the newer anticoagulants, so we're always asking our hospice partners, what are they thinking for this patient? And you got to individualize. It really depends. Is this somebody who's getting prophylaxis, or is this somebody who had a life-threatening pulmonary embolism? But Dr. Marita or any of my colleagues want to talk about how you're handling? I assume it's individualized, but anything besides that to share?
Yeah, it is individualized. It's a really challenging question, particularly because the new anticoagulants are very expensive and usually not on formulary. So that makes a big challenge as well. I personally haven't seen any DVT patients, but then so whenever somebody has leg pain, I always want to be sure to assess it. But I mean, this is just anecdotal. I haven't ever seen one. But my own personal theories. Anything else? I think that's it, huh?
Yeah.
So yeah, anticoagulation is individualized. I'm done.
Is there? I just wanted to correct or clarify what I had said before. So it's 1 in 6, not 1 in 3. Hospice patients are discharged from hospice alive, 1 in 6, and one in 3 of those, the reason for discharge is that they're no longer considered terminal in 6 months. So I said 1/3. It's 1 in 6, but 1/3 of those.
Okay.
Thanks. Yeah, the data. I think the data was recently about 20% across the board in the U.S. specifically, something like that.
17% over the last 3 years. I think the last one I saw was. I saw data through 2017 through 2019 is what I've seen at NHPCO or from MedPAC. Maybe you got something more recent than me.
No, I don't. Thank you.
Yeah, but it runs about 17%, discharge. But again, very consistently, 1/3 of those, it's because they got better. They were at death's door when they came on hospice, but not anymore. So.
Yeah, I have sorry, Mary Gotham wanted to share a couple of stories. So let's see what she has from the nursing front.
Well, these are very personal stories. And excuse me if I'm emotional, but I really, my heart goes out to all of you who try to do these prognosis and everything, because it's so hard. And I want to give the example of my mother. In 1993, when she was 70 years old, she was very sedentary, not in very good health. She went to Kaiser to have a elective surgery, and I'll try to keep this short. I was appalled that they did nothing to prevent DVTs, no stockings, no dining boots or anything. Long story, she got PEs and all kinds of things. And after that, a week or two or so after that, we got summoned to the hospital. She'd crashed And the hospitalist told us, oh, you know, she won't make it through the day. And we all stood around the bed and watched and waited. And she died 21 years later at 91. And second of all, then, I'm sorry, maybe I should, but last year, my 44-year-old daughter was in Queens with lupus, and she had sepsis, endocarditis, pneumonia. She had I never heard of so many opportunistic microorganisms. And I hung on to every word that the doctors said. And I remember one doctor calling and saying, if she lives, and it's a big if, she's in for a long haul. And I would think, what does a long haul mean exactly? And a lot of times the doctors would say, oh, her prognosis is guarded. And I Googled guarded, and I read that means the doctors don't think she's going to live, but they don't want to say so. So they use the term guarded. And, you know, finally it came to the point where, you know, we were told they were stopping treatment. And I can't remember his name. I was hoping it would be Dr. Fischberg, but it was another doctor. He was wonderful. And, you know, her status changed to palliative care. And we brought her home on hospice, and she died here like 3 days later. But anyway, I just want to say that I had thought, because my daughter was 44 and she had inherited her grandmother's strong will, that if my mother could do it, she could do it, but she didn't. And I'm sorry for sharing these personal stories, but I feel like I want to share, because I just want to say, with all the science and everything, we still don't know. And I do appreciate how hard it is for you folks, and how hard you do try to help us out. And even though I'm an RN, in both cases, it was super hard. That's all I wanted to say, I think. Thank you.
So sorry, Mary, for your loss. And it took a lot of courage for you to share that with all of us. And I think it's just a nice reminder to us all in healthcare that, you know, when we speak with our patients, we need to speak in so comments from our team from meeting today about experiences.
Yeah. Even even though I'm a nurse, in a way it helps to have the knowledge, in a way it doesn't help at all. And I wish I could remember the name of that palliative Dr. Fischberg. He was so wonderful. If you said the name, I would know it. He was a Caucasian man. He was very patient and kind and wonderful with me and my son-in-law.
Would that be Dr. Bernstein?
It wasn't Bernstein. Maybe, I don't know. I thought his name started with an R. I could be wrong.
Okay.
Caucasian doctor. Bernstein. Yeah, maybe it was Bernstein. You can tell him
I will.
I'm very grateful to him for what he did for us.
I will definitely do that. Thank you, Mary.
And the worst time of my life, he was very kind and helpful. Yeah.
That will mean so much to him to hear that.
Thank you.
Yeah.
That's right. Never lose sight of that when we speak.
And I think Lucas is making the point that I also wanted to share about what Mary has said. It's so important, you know, when and it's challenging, those of us that in the healthcare field, when we need the help, that we get treated just like everybody else, and that people just not assume that we have additional coping skills or knowledge or whatever else. And it's one of the hardest things. My dad, who was a doctor, always said that. It's one of the hardest things to get just treated like a human being when, you know, when they know that you're in the profession. So Mary, I think you said that very eloquently.
I didn't know if I should share or not, but I just kind of felt maybe it makes it real for all of you who are doing it from the other side.
Very valuable. Thank you.
Thank you.
I think it was Dr. Bernstein, and I would love it if you let him know that we'll never forget him.
Yeah. We'll do that. I
So
promise.
kind. And there was a nurse practitioner on the weekend. She was super too. Can't think of her name either. I'm terrible with names.
Thanks.
I'll find her and I'll thank her.
I don't know, is there one last burning question from Dan Saltman? Or comment? Or?
Well, it's related. Thank you, Ida, and thank you, Mary, for sharing with everybody. It's related to that. It's related to that, those questions and what we've been talking about. And I'd be interested to hear what people's thoughts and comments are about the role of advocacy in prognostication and survival that has to do with, you know, family advocacy or, you know, because that affects, you know, us in the medical field, whether we're going to advocate for our parents in some way. So I was wondering just what people's thoughts and comments were about that idea about how advocacy impacts care and prognosis, say. Thank you.
Yeah, if I might, I think that's a really an excellent question, Dan. I think we alluded to, you know, when we're in talking with Joseph's question, I think it definitely can, absence of advocacy or you know, can have a negative impact. And I think we strongly believe, you know, that even just whether it's advocacy or even just presence, right? I think that's been one of the hardest things during the pandemic is the isolation that the sick people have had to deal with or separated from families. And yet someone advocating for them, but just the healing presence of loved ones at your side, you know, it's just devastating what that's been like during the pandemic. And then it, you know, gets to the self-fulfilling prophecy thing that we were talking about alluding. So it's hard to think that's not having an impact. And it can go the other way too, you know, when people are advocating in a way that maybe isn't so helpful, when there is a devastating prognosis and really no medically realistic hope for recovery, and the advocacy is very aggressively. Sometimes we do worry that we're adding to the patient's suffering or burden. So we see on both sides, but I think it certainly is important to have an advocate, and its absence is an issue. But when we see, you know, unrepresented people in the hospital, there's just the ethical questions: are, you know, vulnerable people who's speaking for them, and who's making sure that they're being represented. Challenges come up. So advocacy, I think you raise a really important point.
Thank you so much. This was really fantastic. Thanks everybody for your sharing and for your input and thoughtfulness and vulnerability and making it all real. So I just want to end of the hour. There's a link in the chat box to take the evaluation so you can get your CMEs. And yeah. Thank you, and we'll see you next month.
Thanks, everyone.
Thank you, Aida. Thanks, everyone.
Bye.